whenever you're ready.
Sorry, I'm still muted. Is everyone able to see it right now?
Yeah, you just gotta enlarge it on that bottom right for presentation mode and you'll be good to go. If you go down,
there we go.
You can do it that way too. There's like the little like where you can scroll. Perfect. There you go.
Okay. Alrighty. Hi everyone. Like I said, my name is Marissa. I'm the PGY1 community-based pharmacy resident at WVU Allied Health Solutions in Morgantown. And today I'll be talking about Hep C treatment and adherence. So my objectives for this presentation is to discuss general tips for adherence and patient consideration, analyze treatment adherence data from studies, identify issues for non-adherence with common treatments, compare side effect mitigation and counseling points, review non-adherence guidance, and finally review non-adherence guidance in the treatment guidelines. So first, I'll be going into some general considerations that are not necessarily specific to Hep C treatment. So adherence is the extent to which medication intake behavior corresponds with the recommendations of a healthcare provider. Adherence is usually reported as a percentage and is the number of doses taken by the patient over the number of doses prescribed. Adherence is usually defined as a patient taking greater than or equal to 80% of the prescribed treatment. So things to tell patients to help increase their adherence could be to set an alarm on their phone, keep their medications in an area where they will see them every day, and add them to a routine that already exists. Some other things that might help them is to write out a physical calendar for when they're supposed to take their medications every day. There are also some mobile apps that can help patients that they can download to keep track of their medications and what they've taken so far today. And lastly, seeing if they have like a family member, close friend, neighbor, or home health aide that can help them with their daily meds as well. Again, some general things to consider when patients may be non-adherence with their meds could be a high pill burden, low health literacy, affordability of their medications, and their willingness to take prescriptions. These are also barriers that are factors that can also be included in Hep C treatments as well, but these are just general considerations for every patient. So there have been some studies done to specifically look at causes for direct acting antiviral therapy non-adherence and Hep C treatments to identify any barriers, like additional barriers that other patients may not be experiencing when going through treatment. So these studies found that in patients that missed between 1 and 7 doses, that 86.1% achieved SVR, and in patients that missed more than 7 doses, only 55.6% achieved SVR. In another study, non-adherence increased by 11% towards the end of treatment. In another study, no missed doses were reporting, I'm sorry, I'm tripping over my words. In another study, no missed doses reporting was higher in the Maverick group, which was 51%, compared to the Epclusa group, which was 29%. So shorter durations of treatments are preferred, and patients are more likely to be adherent. Patients who are younger also are less adherent. Only 71% of patients under 30 reported optimal adherence compared to 91% of patients who were 30 years of age or older. Typically, this is seen because patients who are older are more concerned with their health compared to younger patients. So that just might be something to keep in mind. Another study showed that patients who had a high symptom burden of Hep C were less likely to be adherent to treatment. Non-adherence increased by 6% between treatment weeks 2 and 3 in patients that had a TMSAS scores greater than 1 at baseline. Lastly, studies show that current alcohol or drug addictions have no effect on adherence with Hep C treatments that have short durations. However, there was an increase with non-adherence in drug use in treatments that were 12 weeks or longer. So this top figure here, shows patient-reported missed doses. So you can see here for Mavorite, they have one for Epclusa. And then down here at the bottom, they have provider-reported missed doses for Mavorite and Epclusa. Patient-reported adherence was collected by a yes or no questionnaire, and provider-reported adherence was collected from medical records, patient interviews during clinic visits, pill counts, or use of pharmacy refills. So this data here can be potentially useful in patient education and making sure patients understand what it means to be adherent to their medications. For example, like patients may think they're being adherent and are checking yes or no, but compared to the provider reports, they actually really aren't being as adherent as they think. So really making sure that you're educating your patients on what it means to take their medications. So in this next figure, this one study, they monitored adherence through MEMS or medication event monitoring systems. And from what I've gathered, it's an electronic cap that goes on a prescription bottle and can monitor dosing history, including like the date and time patients take their doses. And it can also monitor for missed doses. So they measured adherence that way, and you can see that adherence significantly decreases in like the weeks of therapy. So the longer the duration is, you can see the more non-adherence there is. This study was specifically done in patients that had active addictions. So that might be something in mind if you have a patient that is currently using to keep the treatment as short as you can. So next, I will be moving into more specific considerations to be thinking about for Hep C adherence. So specific patient considerations, some things to think about are age. Like I said, patients who are 30 years or younger typically don't have good adherence rates, current addictions, historical adherence to therapy, other comorbidities or their current symptom burden, and their willingness to treatment is always something to consider. Some patients aren't at that stage in their life where they're ready to be treated, but they still might be coming to you as a provider anyways. So looking at the drug specifically, Mavorite is 3 tablets all at once or one after the other once daily. It is 8 weeks in duration. It also comes in a pellet formulation that does not taste well. It must be taken with food, and its drug interactions that we see mostly are with statins and ethinyl estradiol. So when thinking about prescribing Mavorite and looking at a patient, it is the shortest duration of all the therapies. So like I stated before, with patients that have like current addictions whose adherence rates are going to decline with longer durations of therapy, Mavorite might be the treatment of choice because it is shorter compared to Epclusa, Harvoni, and Zepatier. Next, can the patient swallow well? Pellets have been used off-label for adults that can't swallow. Like I said, they don't taste good, but they can be used for patients who can't swallow. Does the patient eat regularly or at least one regular meal? Mavorite does have to be taken with food, and there's no required amount of calories. So it can be a small snack, but the patient does have to be a regular eater. And I apologize for the font mistake, but does the patient require a statin? That's the next big thing to consider. The statins can be held, or they can be switched to rosuvastatin with a max daily dose of 10 milligrams. And will the patient have to switch to a non-estrogen containing birth control? So with a female patient, if they're already on a birth control that contains ethinyl estrogens, they would have to be switched to progesterone only, which can be okay, but with norethindrone, it has a 3-hour time window, and some of the other options for progesterone, they have a long return to fertility window, which just might not be the best option if the patient does want to try and conceive right after their treatment. So it's just something to think about when choosing the therapy for them. So next we have Epclusa. It's 1 tablet once daily for 12 weeks. It also comes in a pellet formulation. Again, it does not taste good, but this one can be taken with or without food. And again, for common drug interactions, there's the statins, the PPIs, H2s, and antacids. The one thing that is nice that I did forget to mention about the Mavorite is the packaging that it comes in. I can go back, but the Mavorite does have really nice packaging for adherence. It has like these blister packs that you can pull out for each day. So that can really help with adherence. I apologize, I forgot to mention that. And then the generic Epclusa comes in like a blister pack like this. That's easy for patients just to pop out and see how many they have left. Again, some considerations. Can the patient swallow well? The pellets can be used off-label, just like Mavorite. Is the patient on a PPI or an H2 that must be continued during therapy? The omeprazole 20 milligrams is the only PPI recommended with Epclusa, and it has a really strange dosing schedule. So Epclusa must be taken with food, and then omeprazole is taken 4 hours later. It's not at least 4 hours, it's 4 hours later. So if patients are on both the Epclusa and the PPI, making like a schedule of when they need to take the Epclusa and when the omeprazole is probably the best idea, because it can get really confusing. I think it's confusing personally. I wouldn't want to take omeprazole with Epclusa. But they can take famotidine. It can be administered at the same time or 12 hours apart, with the max dose being famotidine 40 twice daily. And then antacids just have to be separated by 4 hours. And then do they require a statin? Again, it can be held depending on their cardiovascular risk, or it can be switched to rosuvastatin with a max daily dose of 10 milligrams. The Zepatier is next. It's one tablet once daily for 12 weeks. This one does not have a pellet formulation available, but it can be taken with or without food. And it also has really nice packaging. It has this kind of like blister pack that kind of almost looks like the birth control packaging that kind of tells you on the top what day of the week to take it, and it's really easy for patients to follow. Again, for drug interactions, we see most commonly are statins. Again, patient considerations. Can the patient swallow well? There's no pellet formulation for this, so if a patient is having some swallowing issues, this would not be a good drug of choice. And then, does the patient require a statin? Again, it can be held or it can be switched to rosuvastatin with a max daily dose of 10 milligrams or a atorvastatin with a max daily dose of 20 milligrams. And lastly, we have Harvoni. That's 1 tablet once daily for 12 weeks. This one does come in a pellet formulation and it can be taken with or without food. It also, it's generic, also has these nice blister pack formulations that patients can pop out. And then its drug interactions are very similar to Epclusa, the statins, PPIs, H2, and antacids. So some things to consider again, can the patient swallow? Just like the other ones, the pellets have been used off-label for adults who can't swallow. Is the patient on a PPI that must be continued? So doses comparable to omeprazole, 20 milligrams, can be used, but must be administered at the same time of therapy. And I do have like a small chart here of comparable doses to omeprazole, 20 milligrams. This is not the same though for Epclusa. Fortunately, it's just for Harvoni. But famotidine can be administered at the same time or 12 hours apart, just like Epclusa, with a max dose of famotidine, 40 milligrams twice daily. And then again, the antacids must be separated by 4 hours. And then lastly, some patients may stop taking their medications due to side effects. So if we can prevent any side effects or make them more tolerable for the patient, hopefully they will be able to finish their treatment. So all the medications have pretty similar side effects. I typically say to be very open to patients about side effects and what they may experience while taking the medication, but it's always a good idea to use your clinical judgment about counseling patients on side effects, especially if they are known to be overly anxious about side effects or have medication anxieties. I know some people probably have those patients that they think about that if they tell them one thing, they won't take it at all. So that's just always something to think about in the back of your head. But for headaches, patients can take whatever they normally take for their headaches, whether it be prescription medication or Tylenol or ibuprofen. For nausea, Zofran is really the only medication that could be helped other than some non-pharmacological treatments, such as like ginger or mint. And lastly, for fatigue, there is no medication that can really help with any of those side effects, like fatigue, but sometimes maintaining like good physical activity, taking a multivitamin can also help. And then coffee has also been shown to have good antioxidants for the liver. So it may be the only time that coffee is recommended for patients to help with their fatigue. So I just have this slide screenshotted straight from the IDSA Hep C treatment guidelines on how to treat a patient that may have missed so many doses or so many days consecutively, and their recommendations on how to go about those patients. I wasn't really going to go over it today in detail, but just thought it was worth mentioning that there are guidelines that do address non-adherence if it becomes an issue for any patients that that you might have that aren't staying adherent to their treatments. So here are my references, and then what questions can I answer for anyone today if there are any?
Thank you so very much, Marissa. You did an excellent job. and have some great charts in there. We'll make sure we get those PowerPoints to you guys. And I am the patient with medication anxiety. So I am one of those people and I hate swallowing pills. So I'm just like a great, great patient. But I usually just tell my husband, like, read, this is my tool, read these for me. If I show any of these things, then we'll do something about it. So I don't even read them anymore. That is my tip. Get somebody else to read them for you. Pay attention to my symptoms, and then we go from there. But we really appreciate your time, and thank you so much. Does anybody have any questions or comments?
I just also wanted to echo what Elizabeth said. You did a great job, and we thank you for presenting today.
Thank you.
Such a great overview. Thank you so much. It was great. It was succinct to the point. Love it.
Thank you.
Any questions, comments, or stories from, patients or anything that you guys come across?
Shy group today. Oh, Mandy.
Oh, I got my camera fixed now. Okay, so yeah, I had to click a button. I've got a patient that did half of a dose of Maverick, and he's in some legal trouble, which he warned me he might be. So they had called and said they couldn't find him because he was incarcerated. So I called the jail, like I always do, and try to coordinate, at least tell him he needs medicine, because I don't think they listen when they talk very much. But they don't have him either, and I can't find him. He has a warrant, and they're looking for him. So what do I need to do about that? Because he's already done like an entire first dose. I don't know what to do with him. So he could call me from a payphone at any time, but I don't feel like he's going to wait for a shipment from Allied to get the rest of his medicine. So is there anything that I could do other than working with the jail when they finally do pick him up on that probation violation to get his medicine to him? Because nobody knows where he is.
Yeah, I don't think there is, unless he's gonna wait around. Yeah, especially if he's MIA and no one knows where he's at. I think he just needs to be found.
Well, I had an inmate number for him, and I called DCR yesterday, and she was like, "Are you sure we have him?" I said, "It says you do." And no, I don't know. She's like, "Well, maybe he's at one of the smaller jails." I thought, y'all don't communicate with each other. I said, "Could you start in Putnam County? Because that's the last time he got picked up." So I don't know where he is. But he only got half a dose. So will he have to start completely over, or can we just do that refill when he comes out? I guess is my real question. Not just that he's running.
How much again did you say he got?
Got the first half of it, but not the second half.
Okay. I think they have to still just double check to make sure that that his viral load is still positive, and then go from there. I think we've had a couple patients like that, and then what they do is they add on an additional 4 weeks of treatment. So I think he has to figure out whether his viral load is still detectable or not.
Okay, well, I had another one that they were getting ready to ship medicine, and he's incarcerated at Southwest Regional. So CAMC, I forwarded this stuff to them. They're gonna take care of it for me. My people don't behave very well.
Thank you for that. And yeah, they don't. Get on them. Any other questions before we close the session? We get a lot of time back today. All right, well, we really appreciate everyone, and thank you for joining us. The only announcement I have is next time we'll meet will be on October 12th, and it'll be diagnostics treatments for Lyme. So we look forward to that. And if you have any questions or anything, please reach out to me or myself, and have a great rest of your week.
Thanks,
Bye.
everyone. Thanks, Marissa.
Bye, guys.
Thank you.